Surgery at Artemis Hospital. I am Chief of Pediatric Cardiac Surgery at Artemis Hospital, India. I've been with this hospital for about 10 years. So what happened was my graduation and post-graduation in medicine is from India. I did my cardiac surgery residency from India, and my wife both did our US MLs and went to the US. Stayed there for about 3.5 years, did a fellowship with Children's Hospital of Philadelphia, then Children's Hospital of Pittsburgh, and I'm also fellowship trained in robotic cardiac surgery from North Carolina. So came back about 10 years back, and we have established the program here at Artemis Hospital. So when I was asked about a topic for discussion by Mr. Varun, we treat kids from around 18 countries, India and 17 other countries. So the most common issue that we face is the timing, right? Like many other specialties and even more, our work is a lot dependent on the outcomes of what we do will depend a lot on when the kid comes to us. So when Varun asked, according to me, probably the most pertinent discussion I can have with you guys is about the appropriate timing for congenital heart surgery. So let me share my screen with you. I will be a little slow. I'm not tech savvy, so pardon. So Varun, can you see my slides? Varun?
Yes, sir, we can
Yes,
see.
sir, we can.
All right. So timing of surgery in a child with congenital heart disease. This is the topic for discussion today.
So sorry for interrupting. If you can like maximize the screen, sir, that slideshow.
Let me
Button
try.
will be on the bottom.
1 second. Is this better now?
Yes, sir.
Good. So, timing of surgery in a child with congenital heart disease. I believe everybody in this chat group has been dealing with kids that have a heart condition, right? So we all know that the common heart conditions that we have are ASDs, VSDs, canals, tetralogy, and henceforth, right? The n number of heart conditions, and they need different kinds of treatment at different point of times. So why is this discussion necessary? Not just in India, even in the US, European Union, Russian Federation, uh, Middle Eastern countries, we treat kids from everywhere. But there's a common misunderstanding that these kids need to be of a particular age and weight before cardiac surgery can be offered. And this is absolutely wrong. Why? Because the kids that you lose before a delayed treatment, these are not accounted for, right? My surgical mortality may improve, perioperative mortality may improve if I operate on a kid that is bigger in size. But yes, you do not account for the kids that are lost during this waiting time. So uh, the recommendations for treatment, timing of treatment is based solely on the natural history of the disease, right? If there's a disease that kills faster, if there's a disease that has a higher mortality rate in waiting, so the waiting in these situations is not recommended. And in the next few slides, you realize that. So if you see, the first condition that we discuss here is ASDs, right? So ASD, I believe we all know, is a very common heart condition. It is a hole or a communication in the between the upper chambers, the collecting chambers of the right and left atrium. A very simple heart condition, very easily treatable. And what is the time when we treat? This is probably the heart condition in which we wait, right? ASDs are best closed at the age of 3 to 4 years. Why? If you see the graph on the lower left corner, this is survival in the general population, the blue curve, and the red curve shows you the survival in a child with ASD, untreated atrial septal defect. So you'll see that the curves are essentially matching for the initial 3-4 years. So there's no increase in mortality if you wait for 3 to 4 years of age. First thing. Second thing is the tolerance to a heart and lung machine is better if you do operate on a kid that is older in age. And third, if you treat at the age of 3 to 4 years, these kids are essentially having a normal life expectancy, quality of life, without any adverse effect of the 3 to 4 years of delay. And more importantly, these kids will have no memory of what happened. Obviously, open heart surgery is a difficult time for the kid and the family, and they'll have no memory of that. But if you see, if you delay this treatment, for more than 3-4 years, the graph steeply curves downwards. So at 10 years, you see there's a significant proportion of kids that don't survive. At 20 years, almost 10% kids will not. These kids will die from, not from heart failure, but AF, supraventricular arrhythmias. And later on, around 30, 40 years, 20 years of age, these kids will die from right heart failure. So it is pertinent that before the curves starts sloping downwards, you have to give these kids treatment, right? So the optimal age for a simple ASD closure is 3 to 4 years of age. I cannot move forward. Good. So ventricular septal defect. This is the second common defect that we see. This is a communication in the ventricular septum, a communication between the right and left ventricle. These are more morbid heart conditions. They will cause more heart failures. Why? Because they tend to increase the pulmonary artery pressure significantly, right? So before this slide, let us go to the second slide. VSDs, the conventional teaching has been that most will close with time. Yes, that is true. 80% in 80% patients, the VSDs will close. But please remember, these are the small VSDs. The more larger proportion of VSDs that we see is small VSDs, and these close. And so please understand, spontaneous closure is the chances of spontaneous closure is inversely proportional to its size. The smaller VSDs tend to close more, larger VSDs will tend to close less. And one more important thing is that the risk of dying from this VSD is directly proportional to its size. So the bigger the VSD, the higher the chance the kid is dying from the VSD. So it is rare for a large VSD to close. And therefore, for a large VSD, it is definitely never recommended to wait, right, for spontaneous closure. They are more likely to cause death from heart failure than having spontaneous closure. Coming back to the slide, right? Timing of surgery. How do we define timing of surgery in a child with a large VSD? We will not talk about small VSDs because most often they'll not, small VSDs will never need treatment. Moderate VSDs are the VSDs that these kids will have heart failure symptoms but are easily manageable with medicines. And in these kids, waiting for 1 or 2 years is all right. But large VSDs, the chances of spontaneous closure is less. The chances of death is about 9 to 10% by 1 year of age. So the recommended age for surgery is about 6 to 12 months. So this 10%, we are trying to prevent loss of these 10% kids, and we do surgery before the age of 1 year. So 6 to 12 months is the ideal age, but this is only applicable if the symptoms cannot be controlled by medication. Medications are simple, furosemide, aldactone, and digoxin. If you cannot control symptoms by medication, then VSD closure is recommended at any age. It can be 1 month, it can be 15 days, it can be 2 months. But if you cannot control symptoms by medications, send the kid for VSD closures. Nowadays, the intent for a VSD closure in child is that we should give these kids a surgical cure. A surgical cure here is defined as that the kid should be alive late postoperatively with near normal pulmonary artery pressures. And please understand, if the repair is done at 6 months, the chances of a surgical cure is 95% or more. But if it is rare for a child to have a surgical cure if the VSD closure is done at 4 years of age. So recommended age for a VSD closure is 6 to 12 months. AV canal defects. So these are a lot more morbid heart conditions. They have an association with Down syndrome also. So in this, there's a ASD, there's a VSD, there's a common AV valve. The partitioning of the AV valve is not there. And the recommended age of closure for AV canal is 3 to 4 months of age. A complete canal, they must be operated by. Sorry, I believe I missed something. Is it? Varun, is somebody asking a question?
No, sir, I think
Oh,
somebody accidentally got unmuted. It,
done.
it,
So AV canal defects, as I said, they are commonly associated with Down syndrome. These, in this, the pulmonary artery pressures are quite high, way higher than VSDs, and they tend to become inoperable by the age of 6 months. And the risk of dying before the age of 6 months is very high. So the recommended age for repair of an AV canal defect is 3 to 4 months. And so by till about 3 months, the shortness of breath, chest infections, difficulty in feeding, liver, these all can be controlled by medications. But if the symptoms cannot be controlled, repair is done early. The earliest we have gone is about 6 weeks. but because the PVR is higher by around 4 to 5 weeks, but it can be done earlier also if the symptoms are not controlled. And please remember, a child with a complete AV canal defect will be inoperable by around 9 to 12 months of age. If the treatment is delayed beyond 9 to 12 months of age in kids with complete AV canal, they are more likely to be inoperable than operable. And this is more common in kids with Down syndrome. And by around 6 to 9 months of age, if a child has Down syndrome and AV canal, they tend to be more inoperable. And obviously, there are no chances of spontaneous closure. Tetralogy, yeah, this is a very important thing. We in our practice we all see tetralogies very commonly. Very frequently we see tetralogies. So this is a prototype disease when we discuss cyanotic heart diseases in children. The timing of surgery is always dictated by the natural history of a disease. Please understand, the risk of death versus risk of treatment, that is what defines timing of surgery. So if you see the natural history of a child with tetralogy, almost 25% will die by the first year of life, 40% by 3 years. So waiting obviously is not recommended. And when we see a child that is symptomatic, mildly symptomatic or asymptomatic, we do a single stage repair at around 6 to 9 months of age. And symptomatic infants will go for complete repair at any age or weight. And if you see the graph on the lower bottom right hand corner of the screen, you'll see that survival after a repair of tetralogy is very good. So there's an initial drop in survival because of surgical mortality, and beyond that, the curve will almost match the normal population. And if you see the one on the top, survival without treatment is actually really poor. So the risk benefit ratio is heavily in favor of early treatment. So TAPVS, total anomalous pulmonary venous return. In these kids, there are four pulmonary veins. They either connect to each other or separately. They will connect to either the right atrium or one of it feeding tributaries instead of connecting to the left atrium. Very dangerous heart condition. Untreated, only 50% will. This one I would particularly like to stress upon. When I was a resident in cardiac surgery, if a child came to us with TAPVR and a large ASD, they were considered to be simple heart conditions, and we would ask them to wait for about a year. If you look back, these are not simple heart conditions. There are a lot other reasons why these kids die, and almost 50% will die by the age of 3 months. And survival to 1 year is less than 20%. So, if a heart condition has a mortality of 80% by 1 year, surgical treatment is recommended at diagnosis. No matter what the age is, no matter what the weight is, the kid will go for surgery exactly at diagnosis. Transposition of great arteries in the TGAs, the pulmonary artery comes off the left ventricle, the aorta will come off the right ventricle. These kids are profoundly cyanotics. And there are two variants that we discuss commonly. One is with VSD and one is without VSD. TGAs without VSD, survival is really poor, 20% mortality by 1 week, and 80% mortality by around 2 months. And by 1 year, only 4% kids are alive. Very morbid heart condition. Treatment is easy, simple, 95% survival at 1 year with treatment. So, cause of death usually in a child with TGA without a VSD is hypoxia. The second subset is TGA with VSD. Survival early on is a little better, but with time, the PVR will increase and these kids tend to become inoperable. So by 1 month, almost 90% kids will survive without treatment. By 5 months, only 40% are alive. 1 year survival is less than 35%. And most kids at 1 year are inoperable because of high PA pressures. And cause of death in these kids is heart failure. Right? So timing of surgery is in favor of early treatment. TGAs without VSDs, we operate before the age of 2 weeks. The recommended time for surgery is before the age of 2 weeks. It can be delayed to 4 to 6 weeks, but beyond this age, the left ventricle will regress. It will become weak and will not tolerate an arterial switch operation. And then we have to devise ways to make it stronger. TGA with VSD, these kids tend to do a little better early on. So this recommended age for surgery, arterial switch with VSD closure, is 4 to 8 weeks of life. PDA, we all know PDAs are very common heart conditions in there. The ductus remains open, and kids are mainly symptomatic because of a large left to right shunt. They have heart failure symptoms, failure to thrive, shortness of breath. And if the heart failure symptoms are there, closure at diagnosis is recommended because surgical mortality, device closure mortality is very little as compared to heart failure symptoms. And so when the kid with a PETA has a heart failure symptom, we go for surgical closure no matter what the age and weight is. If the heart failure symptoms are not there or they are controlled with medications, we go for device closure at around 3 months of age. Coarctation of aorta, in this, the junction between the arch of aorta and descending thoracic aorta is narrow. These kids will have a very high afterload. The heart is pumping against a narrow aorta, and so the risk of dying is about 30% by around 1 year of age. And beyond that, because the kid will get a little adjusted to this heart condition, the risk of mortality is still 1.6 to 2% per year from various things. And so whenever a diagnosis of coarctation of aorta is made, the timing of surgery is immediately after that. And the bigger reason the reason we do that is to prevent these 30% kids from dying. And the second reason is that when there's coarctation of aorta, there's upper body hypertension. So if these kids they are not treated in time, the hypertension tends to stay for a much longer time. So if you treat these kids early, the chances of hypertension late post-operatively is less. If you treat the kids late, then they will remain on antihypertensives probably for life. Truncus arteriosus. Truncus arteriosus is a heart condition in which there's obviously a VSD, and then there's one truncal artery that comes out of the heart. It will give rise to the pulmonary arteries and the aorta. So mortality is quite high. Untreated, only about 50% will survive the first month of their life, and 30% beyond 3 months. And as before, when this heart condition has such high mortality early on, survival after surgery is reasonably good. Surgery is recommended exactly at diagnosis. If the kid is a newborn, surgery is done at a newborn age. And to summarize these heart conditions, as you can see, the only heart condition that is treated later is an atrial septal defect. The rest are either treated under the age of 1 year or best at diagnosis. For example, TGST, APVS, coarctations, truncus, pulmonary atresia, single ventricles. The treatment starts at diagnosis. The remaining, yes, the timing can be a little different. How do you get good outcomes when you are treating such complex heart conditions? The criteria that are set are very stringent. According to the British Medical Journal, there are 9 criteria that a program must meet. So for the past 10 years, we at Artemis Hospital have been striving to make sure that we tick mark each and every requirement for a good program, and we match our infrastructure and outcomes with the Western world. We also have a very active Womb to World program. So what happens is in these kids, mothers have a fetal diagnosis of a heart condition. They will come to us. The delivery happens in our under our Womb to World program. The kid will come to my pediatric cardiac ICU. They get treatment, they get surgery, and then they go back home. We also have heart failure clinics, fetal cardiology clinics, pulmonary hypertension clinics, arrhythmias and pacemaker, adult congenital heart disease and heart valve clinics. We are treating kids with advanced heart failure. We offer transplants, pediatric LVADs, ECMOs, and we are offering treatment for primary pulmonary hypertension and CRRTs. We are a group of 40 healthcare providers, and we take care of kids with heart condition. And our hospital is a huge hospital in northern India. It is a 750 plus beds. We have 12 centers of excellence, 40 plus medical specialties, 400 doctors, and we are JCI accredited. We are the first hospital to be JCI accredited in Delhi NCR. Thank you.
Thanks, Dr. Aseem. So there's a question from Dr. Avok. He practices in Ethiopia.
Mhm.
So he asks,
Hey, Dr. Vok,
Hi, Dr. Avok.
how are you?
Dr. Avok, you can ask the question directly, or I'll read it out since you shared on chat.
Okay, thank you, Barum, for inviting me, and thank you, Dr. Asim, for concise and clear presentation today. I do have a few questions. The first one I already wrote in the chat was the timing for patient or kids with transposition of great artery with BSCD and LVOT obstruction. And the second most important question is, since we are living in a resource limiting country and the diagnosis even can be made after lately, and the patient might ask for abroad treatment after being diagnosed lately. So what's your recommendation? Because majority of cases, including simple shunt lesions, the diagnosis is being made late, and they may become panic, and they will ask to go for abroad for surgical intervention. So what's your recommendation for such kind of
Very
patient?
important, Dr. Oak. So the first thing is that a very good question is that VSD with LVOTO, right? So TGA, VSD, LVOTO. These kids essentially have pulmonary stenosis and VSDs. The timing of surgery will depend on the kid's saturation, right? So these kids will either go for a Rastli operation or a Nikaido operation, right? So both will need an implant. The intent is to give them a bigger implant if possible, right? The smaller the implant, the earlier they come back for implant change, right? If the saturations are above 75 and the kid is growing well, the kid is doing well, then they can obviously wait. But if the saturations are less than 75 and the kid has significant failure to thrive, then they should come for surgery at any age or weight. If the saturation is less than 75, they have to come early. More than 75, they should obviously wait and come for surgery at around 1 year of age. A Rastli operation or a Nikaido operation. The second question, late presenters, we are also a resource limited country, right? So as I said, we are 4 or 5 people in northern India, half of India. We are a very populous state, country, right? So 4 people in half of India doing this kind of work. So we are also resource limited, and the problem that you face, that kids come late, we are facing it every day or two. Till now, I have not been able to find an answer, but uh, my suggestion would be that we have started education programs in different centers. We are pulse oximeter screening any kid. So what we do is, in India, when I go for a CME, I promote pulse oximeter screening. So you're a pediatric cardiologist in your country, you can take it up and you can try it, help your pediatrician understand the significance of saturation measurements at birth, 1 month, 6 months after birth, and then they can refer for echo early on. Late presenters, PDAs, usually they are operable. Tetralogies, blue heart conditions, apart from TGAs, they are usually operable if they are late, even with a slightly higher risk. But unfortunately, VSDs, shunt lesions, they will be inoperable. But believe me, I have seen when the clinical sense says that these kids are inoperable, we do a cardiac cath, a significant, not large, but a significant proportion will turn out to be operable. High risk, but they will be operable. So currently, I will always offer a cardiac cath. Even if a kid is late, I would always offer them a cardiac cath to confirm. And plus, once confirmed that these kids are inoperable, you can always counsel the families that they should not run around. They should just stick with medical management, because if they are in, for example, a VSD child with VSD is inoperable and he gets good medical care, they will still survive 25, 30, 35 years, right? But if they do not get that skilled medical care, appropriately timed diuretics, appropriately timed pulmonary vasodilators, they'll die much earlier. So you see a kid who is not operable, you can still prolong life and improve his or her quality of life. I hope I answered that, Dr. Vogue,
Yeah. Thank you.
right?
Dr. Vok, you can in fact discuss your current patients, for who consulted Dr. Aseem, for benefit of other participants, like the condition, and if you want to. I mean, of course, you can keep their name anonymous.
Okay. Am I audible?
No,
Yeah,
you have,
absolutely.
you're
Okay.
audible.
Yeah, thank you. So my clients, some of them are already processing the passport and the visa process, but still they are latecomers and they are just trying to try the last option for the kids. So they almost 3 of them are on process. One patient with TGA, she already dropped the abroad treatment because outcome is poor, and even she cannot afford for outside treatment. And currently she is 8 months, and she is complicated. She had the frequent hospital admission every month, and the outcome is guarded. And even the mother called to me, and she declined the abroad treatment. The other kid, the one with rheumatic heart disease, as I told previously, she is a refugee, and she doesn't have any family member to go abroad. And if they had any updates, they will update me, and I will update you as well.
Dr. Awok, what I meant was that the medical condition aspect of it, like the problem with the kid, what Dr. Aseem suggested, and so that others can also benefit.
Okay. Sorry.
Right.
So I will try case by case.
Okay.
So the first case is when we do consultation, a 6-7 months old infant who presented with bluish discoloration of lip with recurrent pneumonia admission, and she was diagnosed to have transposition of great arteries with BSCD. And we discussed with the Jivo team, and the family even tried opted to abroad management. We counseled them to have early surgery as soon as possible, but even she came late, and we counseled there if there is option she can try. So we communicate with Dr. Asim, and the decision was at that time to come as soon as possible, but due to financial shortage, they were collecting money for past 2-3 months. So almost currently she is 10 months, and she had since then she had, I think, 4 hospital admission with heart failure manifestation and pneumonia. And recently the mother told me that she had a shortage of money, and she declined for abroad treatment. The second one, 11 years old female child who was having a follow-up with chronic rheumatic valvular heart disease with severe MR, severe MS, and atrial fibrillation as well. And I was following her with medical management, but she should have a surgical intervention for mitral stenosis, and I counseled them, and she is refugee, and she had organizations that support her medical treatment, and I committed them to have early surgical intervention. Unfortunately, we communicate with the family member, and the healthcare provider that follow her told me that she doesn't have any family member, and they were searching family member to accompany her for abroad treatment. Still, they didn't decide on that, and they couldn't found any family member to accompany her.
Okay. Thank you, Dr. Awok. So basically, I think there was another question by Dr. William Gadaga. He's from Zimbabwe. And Dr. Aseem has already answered. Those of you who are not reading the chat, the question was, what's the average cost of ASD closure? It's approximately 5,500 USD. Any other questions from anybody else?
So Varun, I have a small suggestion.
Yes.
So Dr. Work and everybody who's listening to this, I have a small document. It's about 4 or 5 pages. So Ministry of Uganda, they send kids to us very frequently, right? And what was happening was when they were sending kids, many of them were late for surgery. So they had to go after cath, they were found to be inoperable, they would go back without treatment. So when the minister was visiting us, he came to my office and said, Dr. Singh, what we want from you is a small guideline because a lot of us are not from a medical background. And a lot of us, even if they are doctors, they don't know much about congenital heart diseases. So can you build a guideline for us so that we can make that as a base document on when to refer kids. So I have that with me. So it
Okay.
was also translated in their language. I think it's Kwasheli or
Swahili,
Swahili, Swahili,
in
right?
Uganda
But
it is Swahili.
I have also an English version. So if you can share your email IDs or WhatsApp numbers with Varun, I can share that document with you guys, and
Okay.
it's a good
So
read.
what
So
we will do,
whenever,
sir, if you share with us, all of these
Mhm,
doctors, they have a workbook
Okay.
with us and email
mhm,
ID. So we'll circulate
mhm.
it. We'll
Absolutely.
circulate it.
So it's a very good read. Have a cup of tea or coffee, whatever your poison is, and sit in the evening and just go through those 5 pages. And I'm very hopeful that it'll be helpful for you guys.
Okay. So till then, any other question? If somebody has any other question, if you don't have any question right away, it's okay. You can always share it with us, and we will share it with Dr. Aseem and his team, and within a reasonable time frame. I mean, you have to allow for some time because surgeons they have a busy schedule, but within 2 3 days, we'll get a response from Dr. Aseem or his team. Uh, uh, okay, sir, you have already answered the question when to identify and when to make a referral. You will share that guideline document. Also, sir, if you could, just say a few words, because many of the doctors, they would see patients, even if they are a fit referral case, the family may not have financial means. Now, I understand it all boils down to medical management, and they may require certain guidance from a specialist like you.
Mhm,
So, what we suggest that when you face such a case, the simplest way is you write a doctor's note to us, which we share
mhm,
with the specialist. So, one doctor to the other, the knowledge transfer can
mhm.
happen. But
Absolutely.
if you say it, sir, that gives them more assurance because you as a specialist are saying it, not me. Yeah.
So, what is happening is when we treat kids, it is not just a one-time thing, right? So, I have to make sure that they are safe before surgery, and I have to ensure that the doctors treating them have easy access to me after surgery, also, right? So, in fact, this is a very good point that you brought up. It will be helpful. So, if I can treat more kids through you and the referring physician, doesn't matter if they come for surgery to me or not, I'm still helping them out. I'm always available 24/7. I might answer a little late if my schedule is a little tight, but I will also always answer. And it is always nice to help kids, right? So doesn't matter if they come to me, if they come to some other center, right? If I'm helping a kid, I'm always happy to do that.
Okay. Thank you, sir. That means a lot because many a times, our African doctor colleagues they face this challenge.
No, no,
Now they
I'll
are
be available 24/7. I'll be available.
and many times just the right guidance from an Indian specialist may help them manage the case better locally within the constraints, of course. And thank you for that support, sir. So you can ask any questions later on also after the event. Around in an hour, you will receive a email for a feedback. You will have a form also. If you feel there is a case that you want to submit to Dr. Aseem, you can submit it through that and give your feedback. And perhaps, sir, after 2 3 months down the line, we can have a repeat session in pediatric cardiology
Absolutely, absolutely.
because the
It
field
will be
is
helpful if somebody can suggest what they want to talk, because this was from me, right? If there's a need that has to be addressed, I will be happy to address that need.
we will discuss it with the doctor network and ask them to suggest a topic and run it through you, sir.
Done.
So if
Absolutely
we have your permission, sir, we can conclude this.
done. Have a
And
good night.
before that, let me thank everybody for taking time out on a Sunday. I have many doctor friends. I work in healthcare industry. I know this is the only day you get for your families. And those who joined from Africa, hats off to your commitment in learning. And Dr. Aseem, I know how busy schedule you keep. I'm
Thank
personally
you.
aware of it. And
Thank
thanks
you,
for
Varun.
taking time out. Thanks for taking time out to
Thank you.
interact with our doctor network. Thank
Thank
you
you.
so much.
Good night. Good night, everyone. Good night.
Okay.